Can I have a presentation? It's FP495, I think. Good morning, everyone. I'm going to present a study related to safety and efficacy of suprachoroidal triamcinolone versus intravitreal dexamethasone in diabetic macular edema. As you know, diabetic macular edema is one of the leading causes of vision-threatening complication of diabetic retinopathy, and we have established option of anti-VEGF and steroid for treating this. In our study, it's a hospital-based prospective comparative study with a sample size of 25 cases in each arm and a study duration of 18 months, as it was a part of the post-graduation thesis, and it extended in 2 places of Odisha. We have a detailed collection of data, pre-treatment and post-treatment evaluation in each part of the eye, and the data was compiled in a statistical method. The inclusion criteria were type 2 diabetes with good glycemic control and the CMT between 300 to 600 microns. But conditions like chronic kidney disease, other vascular disease, pregnancy, and ocular complication like advanced glaucoma, thin sclera, or previous history of scleritis were excluded from the study. So we here adopted a novel technique of designing a innovative injection system for suprachoroidal injection. We have taken 22 gauge needle from just a simple IV set and a 26 gauge needle which is available in each OT. So the measurements were taken exactly taking the hub excluding the needle tip and preparing a guard, thereby preparing a suprachoroidal needle which will reach the suprachoroidal space, which is assumed between 900 to 1000 micron. And the injection is given as usual in the infratemporal site of the eye, and the outer 22 gauge needle shaft provides as a guide, which I have already described, and dexamethasone is given as usual. The 2 arms consisting of 25 patients each, both of them received intravitreal dexamethasone and ACTA on first week, and they are seen in every 4 weeks at 4, 8, 12, 16, 20, and 24 weeks. But we followed up the patients in each visit, and as for the need, the second injection of SCTA was given, which you can see here. The CMT in the blue is showing suprachoroidal triamcinolone acetate, and the red one the dexamethasone. The CMT was higher in ICTA group initially, but finally it almost matched with the IVD group. The visual acuity is also a little less decreased in SCTA group initially, but finally the improvement was better than the IVDA group. So to discuss, we had in each group 25 patients, 15 and 10 male to female ratio in SCTA and IVD 17 to 8, and the mean decrease in visual acuity was almost similar, with no great increase in IOP or cataract progression in each group. As you can see, 3 out of 6 patients which had some amount of cataract progressed in the grade of cataract, and 1 patient in the SCTA group developed new cataract. 4 out of 4 in IVD group almost progressed some amount of cataract, and there are 2 patients who developed new cataracts. So earlier we tried to see the earliest studies available, and one in SCTA group and an IVD group, and both were showing similar results in decrease in both CMT as well as improvement in visual acuity. So we found that mean improvement in visual acuity and CMT were gradual over 24 weeks in both the group, but ACTA is unequivocally superior in cost, in terms of cost, because it was almost within 100 rupees, 100 200 rupees costing of the triamcinolone, as well as preparing the needle for it. But dexamethasone costs around 25,000. So definitely it is a cheaper alternative to IVD, and this is being presented for publication now. Thank you so much.
Two questions. How did you measure 900 microns using the caliper?
No, you cannot. You have to leave the bevel part, and exactly you have first you have to measure the 26 gauge needle, and just again you have to measure the from the needle hub to that starting of the
Okay, so
bevel.
you just cover
Yeah,
that.
so that you can cover. And also,
Yeah, go on. Go on.
and
Finish.
also you can also do a post-operative ASOCT we have done in our cases to confirm the presence of triamcinolone in the suprachoroidal space also.
Did you do pre-operative anterior segment OCT to look at the scleral
That is the
thickness?
best way to decide scleral thickness.
Yeah.
We have excluded the patients with thin sclera or previous scleritis.
No, even in the patients who
Yes,
you
yes.
want to inject, it would be a good idea that at the injection site, you do a pre-operative
Yes, sir. Yes,
scleral
that
thickness
exactly can give you a length of the thickness of the sclera.
And why did you use? Why didn't you use preservative-free triamcinolone? The one which you showed that contains benzyl alcohol, I think, as a preservative. So, what was the reason you did not use a preservative-free?
It is
particular reason?
Cost is a little higher.
We have Indian ones which are not so.
We'll definitely consider your suggestion. We have not used.
Santosh, I think that was one. There are two suggestions. One is, I think you should use a 30 gauge needle, not a 26 gauge needle, because the outer diameter.
This study is 3 years back. Because follow up. Yeah.
So a 30 gauge needle has got a smaller diameter. The only thing is Kenacort does not go through a 30 gauge needle. Kenacort goes to only 26 gauge needle because of the particle size.
Yes.
So we had done scanning electron microscopy on triamcinolone and done a particle size analysis, and we found that this Kenacort will not go through, will go through 30 gauge, but will go through a 26 gauge needle only, will not go through 30 gauge. So that is one suggestion. Second
30 gauge, you are suggesting to use 30 gauge, but you are again telling it will not go through 30.
No, in a 30.
Orolab one goes through 30
Orolab one
gauge.
goes through 30 gauge.
Okay.
Kenacort does not go through 30
Okay.
gauge.
So
Okay.
to change the company, Orolab.
Yeah, that is preservative free.
Okay, done.
Second thing is,
Good message.
I personally do not like the idea of breaking a needle, putting in a needle, because the only thing one is afraid of is introducing infection into suprachoroidal space. If ever it happens with any one of us, it will be a disaster.
Now I think commercially it is available, the suprachoroidal needles.
Use the commercial ones. They work sometimes. Most of the time
They work well in every time, sir? They work well, good every time. Oh, then you have to prepare.
Let me add what sir has said. The particle size may be larger, but normally what I practice is I withdraw in an insulin syringe. I use my insulin syringe for all the suprachoroidal injections. So I withdraw in the insulin syringe. So once you withdraw, all the particle size which are smaller in size will only come. And then I change the syringe and then inject.
But insulin series, the needle is fixed.
So I change the syringe. Once I withdraw in one syringe, I transfer it to another syringe, put the guard in it, and
From you have to remove the plunger.
And the size of the bevel is 1 millimeter exactly. So whenever you make a guard, that guard has to be just behind the bevel. So it will go into the suprachoroidal space.
Understood. So the third suggestion is change the needle. Use insulin syringe.
It's a finer needle.
Yeah.
See, if you look at the sizing of the needle bevel, I don't talk of the needle. just over the needle bevel. The needle bevel is 1200 microns of a 30 gauge needle.
Yes.
A 26 gauge needle is about 1350 microns of the bevel. And when you're going through a sclera, the sclera at infratemporal quadrant is maximum about 0.9 or 1 millimeter.
So
that means you are partly in and partly out.
So as I have shown, initially I go in a sloping manner and then make it vertical to reach. But that definitely is a little blind.
And the other
I
thing
mean,
which suggested is
self-judgment.
the particle size of Canalog is smaller than particle size of Orolab. So the reason it doesn't go through a 30 gauge needle is different. So we had measured the particle size of Canacort is 4 microns. The particle size of Orolab is 4 to 8 microns. So it varies.
Thank you for all your suggestions.